So I think there's a multitude of things that we can do to better recognize people who are entering primary care, but it's not just about training new physicians. I think it's important for us to consider educating physicians who are already in practice today to become primary care physicians, but the right incentives have to be in place for them to be willing to undertake those changes. One final point in that regard, there more than likely will be a need for us to do much more in the area of nurse practitioners as well. And as I mentioned in my remarks, if you recall, today there's a need for about 17,000 primary care doctors as they're needed right now in our country. If we're graduating 26,000 physicians a year, it's going to take a long time to fill that pipeline. So we really need to begin thinking about what are other things that we can do other than simply try to fill the gap with the primary care physicians who don't exist today.
Mr. Zenty, your comments on the single-payer system are interesting, but clearly we have opted for a market system with insurance at the center and many providers, many insurance carriers, and many consumers. But to make a market system work, you have to have price bargaining. And there's some of that that goes on between big provider systems and big insurance companies. But my feeling as a consumer is that the missing price bargaining is at the individual level, the level of a patient dealing with a doctor. And I have had occasion in the last 2 weeks to deal with one of your doctors, an absolutely superb practitioner, and he suggested a procedure, and I said, how much will it cost? He didn't have a clue and didn't know how to find out. So how am I supposed to evaluate whether or not it's a good bargain? The sad thing is, even after the fact, if you have a procedure and get the bill, it is an impenetrable morass of costs asserted at a high level, discounted and counter-discounted, and then there's a little copay at the bottom. But the whole thing is such a confusion that you push it off to one side and certainly don't enter into active price bargaining. So this is something over which you have control. You could create within your system an effort to inform patients before a procedure is opted for what it will actually cost for that particular patient and that particular patient's insurance. My problem is I'm afraid you have a disincentive to do it because that would cause some people to say, oh my gosh, thank you, no thank you. Would you comment?
Let's go to the next question. Well, first of all, I'm glad you had a great experience. So that's the good news. I can take up the remainder of our time today with the answers to your question, but let me try to do this in about a 2-minute or 3-minute summary. The estimates are that if we could improve the administrative side of what we do in healthcare today, meaning the billing and the collection and all the things that go along with it, which, by the way, are not an issue for the most part in single-payer systems, right? So we acknowledged that earlier based on the question that was asked. But if we were able to improve our administrative systems, we might end up saving as much as 20 to 30% of the entire healthcare bill today. Now, who knows whether or not those numbers are 100% accurate, but directionally, let's assume for the moment they're correct. So let me take this through a couple of different levels. First, for those people who come to our system, and this is true of virtually all systems in the country, and they don't have insurance, and they don't have an income, or they have limited incomes, we have a sliding fee schedule that we apply in a very appropriate fashion at university hospitals, but this applies on a national basis for the most part. So virtually all health systems in this country have sliding fee scales. Likewise, we have payment amounts that we negotiate with virtually every payer with whom we have a contract. And then when you overlay on top of that, we have the Medicaid system, and then we have the Medicare system. And then we have a system of copays and deductibles and reinsurance. I've got to admit to you, it is a very challenging environment for all of us to operate, both as caregivers, as healthcare providers, and as patients. It's not surprising to me that the physician in our system who you referenced wouldn't know the answer to that because there are so many different contract relationships that we have that it would be impossible for them to have this information. However, that person should know who to contact, so we can take care of that right away. But when we look at the complexities that go along with our overall billing process, we will see more of what you just described in the future. Mostly because what we're going to be looking at will be things like bundled payments, meaning that hospitals and physicians will be paid a flat rate together. So that will resolve the issue that you talked about. People will be buying healthcare services on the basis of outcomes, which maybe I was a little oblique in my comments, but that's what I meant by when I talked about transparency. So you will see more information published on websites so that we comparison shop for everything. We comparison shop for clothing, for cars, for gasoline, for groceries, but we seldom comparison shop, as you just described, for healthcare. And that's because it is such a complex but not an impossible process. So there are ways that we can address, and we will address, the things that you referenced regarding our health system. But there isn't one simple, easy, one-size-fits-all approach to the issue that you raised. But we will move in that direction as an industry. We must move in that direction in our industry. But once we begin to get some clarity over the next 3 years about insurance reform, I think we'll have a much easier answer to the question that you raised.
Is there health care for college students whose parents do not have health insurance?
Can you repeat that, please?
Is there health care for college students whose parents do not have health insurance?
So are you in college? Not yet. Well, the health reform that I just talked about talks about a number of issues that are going to be happening in the health insurance industry. And so either through a health insurance exchange or through mandated health care insurance coverage, when everyone has insurance today, what I referenced in my remarks is that children up to the age of 26 years old will be able to have that coverage. So it may not be the case today, but that's the direction in which the whole health insurance industry is going to be moving as soon as this legislation gets impacted.
Mr. Zenty, over to your right. Throughout the world, there are different systems, as you know, for paying for health care, and many of them do not rely on the profit incentive to provide that care. Could you comment on for-profit versus non-profit insurance systems and their efficacy?
There is a great book that was written by, I believe, a former NPR commentator, T.R. Reid, that's called The Healing of America. And I have no economic interest in whether or not you buy or read this book, but it's a great comparison of a number of developed countries' insurance programs around the world. And he himself accessed these various healthcare systems with a physical problem to make the determination of what they would propose that he would do in order to have his problem addressed. It's a very interesting read if you haven't done so. It's a very challenging environment in which hospitals operate today because, as I mentioned, the profit margin for not-for-profit hospitals alone, and I'm not sure that's the nature of your question, is about 1.5%. So when you hear about rising hospital costs, it's not as if the not-for-profit healthcare industry has a very large profit margin. In fact, it's relatively meager, and as I said, in 2008, about half the hospitals in the United States lost money from operations as well as from operating income. The for-profit healthcare system that we know today, hospital system that we know today in the United States, actually appears to be faring relatively well under healthcare reform because they tend to be mostly primary and secondary care hospitals, not hospitals that are taking care of very complex types of cases or procedures.